Hello, I'm Paul Carbone, and on behalf of my colleagues in the Department of Pediatrics at the University of Utah, I'm happy to present the findings of our quality improvement project titled Sustainable Telehealth for Children with Developmental Disabilities within a Multidisciplinary Clinic. I have no disclosures. Telehealth is an emerging technology that enables a potentially convenient alternative for the care of children with developmental disabilities when in-person examination is not needed. While there's been some promising small-scale studies, there are unanswered questions as to which types of visits from multidisciplinary developmental evaluation teams are feasible and how to scale up and sustain telehealth visits for children with developmental disabilities. Our multidisciplinary developmental clinic is located in the urban center of Salt Lake City, Utah. In 2016, we established a telehealth program to address several local challenges. First, we needed to discontinue a previous model of traveling by airplane to rural areas for in-person clinics because of logistical challenges and increasing costs. And second, many families needing our services live in rural and frontier counties of Utah, which makes travel to our clinic difficult, especially during the winter months. Over a 4-year period of providing telehealth services for children with developmental disabilities, we sought to describe patient, family, and provider characteristics of completed telehealth visits, evaluate process changes over the 4 years as measured by the proportion of the total visits performed by telehealth, describe patient characteristics and activities performed during one type of telehealth visit that's commonly done in our center, that being ongoing follow-up visits by pediatricians, and lastly, to assess family perceptions of telehealth visits. Over the course of 4 years, we've implemented several process changes to the program. The first, the availability of university-wide telehealth software, has allowed a stable platform to provide direct service into patients' homes. The second was the establishment of a telehealth coordinator, a full-time administrative position within our clinic to assist families and providers with technical aspects of telehealth. And most recently, we began obtaining developmental history during a 1-hour welcome intake telehealth visit, even for families who live closer to our center. This is our current care process model for multidisciplinary autism evaluations, which are the most common referral we receive. A team of advanced practice clinicians, speech and language pathologists, occupational therapists, psychologists, and pediatricians perform sequential visits with families in order to rule in or rule out an autism diagnosis. We initially identified 2 visits that could feasibly be done via telehealth. The final visit by psychology when feedback about diagnostic findings are given to the family, and follow-up visits with our pediatricians who assist families with ongoing care after the diagnosis. We subsequently replaced a mail-out intake packet designed to elicit developmental concerns and history with a welcome intake visit with our advanced practice clinicians that could be done via telehealth if the family desired. Over the past 4 years, our teams completed over 12,000 visits, with 9% of them completed via telehealth. Among the more than 1,000 telehealth visits, about a third have been done with rural dwelling families and 2/3 with urban dwelling families. This table shows patient, family, and provider characteristics from telehealth visits. About 50% of children seen were 5 years and younger. Most were male, reflecting the typical male to female ratio of children with autism. The majority were non-Hispanic white, and 2/3 had private insurance. Telehealth visits were performed about equally between pediatricians, psychologists, and advanced practice clinicians. This is a P-chart showing the proportion of all visits with rural dwelling families provided via telehealth. The y-axis shows the proportion of visits provided by telehealth with center lines and upper and lower confidence limits. The x-axis shows the months of data collection beginning 1 year prior to the start of the program. Specifically, the center lines show that after adopting new telehealth software, about 14% of visits were done by telehealth compared with none at baseline. This increased to 20% with the establishment of a telehealth coordinator and transitioning away from travel clinics, then to 22% after adding welcome intake as a potential visit. Special cause variation was noted in April 2017 and February 2019 when there were major snowstorms. This is a P-chart showing the proportion of all visits provided by telehealth to urban dwelling families. There were increases in the proportion of telehealth visits with each phase change. What's notable here is that the addition of a telehealth option for our welcome intake visit increased the proportion of visits by telehealth among urban dwelling families from 5 to 15%. Seasonal variation was noted for both the urban and the rural cohorts. Next, using data obtained from our electronic health record, I'll describe patient and family characteristics of pediatric follow-up telehealth visits, as well as some of the activities performed during these visits. About 2/3 of pediatric telehealth follow-up visits are with children with autism. Slightly more than half were with families living in rural or frontier counties. The most frequently diagnosed co-occurring conditions from these visits are ADHD, anxiety, and insomnia or sleep problems. About half of all visits involve prescribing of a medication, and the medications that are prescribed most commonly are for anxiety and ADHD, but some are for sleep problems and gastrointestinal conditions as well. So next I'll report the results of a family satisfaction survey that we send electronically after each telehealth visit. From 1,107 visits completed, we received 418 surveys for a response rate of 38%. Most families were in their homes during telehealth visit. The large majority reported ease in hearing and seeing the provider, as well as using the telehealth system. 70% reported no technical problems, either before or during the visit. This graph shows the amount of time that families waited for the provider. The majority experienced no waiting or waited less than 5 minutes for the telehealth visit to start. A large majority of parents agreed or strongly agreed that telehealth saved the family time and money. Most respondents reported that they would definitely use telehealth again, and 70% felt that their child received the same level of care had the visit been in person. And lastly, the comfort level of families utilizing telehealth increased significantly from prior to after the visit. To conclude, we've shown that a telehealth program for children with developmental disabilities can be sustainable over time and have identified 3 visit types that have not required in-person evaluation. Process changes to the program, such as having dedicated administrative staff to coordinate telehealth visits and identifying appropriate visit types, were associated with an increase in the proportion of visits that we were able to do by telehealth. While we initially envisioned telehealth benefiting rural dwelling families, urban dwelling families have shown interest in this option as well. Post-visit surveys indicate a high level of family satisfaction with telehealth visits. There's several aspects of this project that could limit reproducibility in other settings. First, our program utilizes a telehealth coordinator whose effort is subsidized by our pediatrics department. Second, reimbursement rates for telehealth visits in our environment were identical to in-person visits, but this might not be the case in all other locations. And lastly, we had a relatively low response rate to our post-visit family satisfaction survey. Our findings underscore the importance of administrative support personnel and identifying appropriate visit types in order to sustain a telehealth program for children with developmental disabilities. Our experience using telehealth prior to the COVID-19 pandemic has prepared us in making the rapid transition that's been required to continue to serve this population during the pandemic. We're currently expanding the types of telehealth visits that we're providing and look forward to reporting these outcomes as our next step. Thanks for joining, and feel free to contact me with questions, comments, or feedback.